Thank you so much, Lenny, for that kind introduction. I want to say I'm really honored to be a part of the faculty for this conference. And I have the ability today to talk to you about is cytogenetics relevant in the genomic age? And I'm going to start by telling you that I am not a cytogeneticist. I'm a molecular geneticist, and so I'm a little bit biased when I started putting this talk together. But hopefully I can prove to you by the end that cytogenetics is still relevant. So ALL, which I don't really need to tell you, is the most common childhood tumor. And although more than 80% of children that we see are cured, relapsed ALL is still a leading cause of childhood morbidity and mortality. So I really think of this, as we've seen today, as a genetic disease, as most patients harbor acquired somatic mutations that cause increased proliferation and impaired differentiation of lymphoid hematopoietic progenitors. And the majority of all ALL cases, as we've heard so far today, are characterized by distinct constellations of structural and submicroscopic genetic alterations, as well as sequence mutations. So I'm probably the fourth person to show you this slide today. But it's an excellent slide, which is why I think you've seen it so much. I got this slide courtesy of Dr. Mulligan, who is in attendance today, and it illustrates the frequency of cytogenetic subtypes of all pediatric ALL. And Dr. Sassoon had mentioned in his prior talk that at least 75% of all cases harbor a recurring chromosome alteration, deletion, duplication that we can pick up by karyotyping, FISH, or molecular techniques. I think maybe that number could even be higher with our own personal experience. In B progenitor ALL, these include hyperdiploidy with greater than 50 chromosomes and hypodiploidy with less than 44 chromosomes that tends to include also near haploidy. And chromosome rearrangements, including translocation 1221, also known in the medical literature as ETB6 RUNX1, as well as translocation 119, TCF3 PBX1, seen here, 922, BCR-ABL, and rearrangement of MLL at 11q23 to a diverse range of fusion partners. T-lineage ALL is characterized by activating mutations in Notch1, as well as rearrangement of transcription factors seen here, which are TLX1, TLX3, LYL1, TL1, and MLL. And although these rearrangements discussed are very important initiating events in leukemogenesis and are widely used in diagnosis and risk stratification algorithms, they are really insufficient to fully explain leukemogenesis. And rearrangements such as ETB6 RUNX1 can even be present years before the development of leukemia, and many do not alone result in the development of leukemia in the experimental models. So in short, I think genetic studies are essential and provide the most disease-defining, prognostically relevant, and therapy-determining data. However, due to the range of aberrations that I talked about, it's very obvious that we need different cytogenetic and molecular genetic technologies to ascertain them. And today I really wanted to focus on some of these technologies and where we have come from and where we continue to go. So chromosome analysis reveals alterations typically greater than 5 megabases in size in a high-resolution preparation, which is what you see here. As many of you know, and I'll show a picture in a future slide, most bone marrow karyotypes of acute lymphoblastic leukemia patients don't look like this. They're much lower resolution, and often deletions or duplications could be 10 megabases or larger prior to be detected by conventional cytogenetics. The sample that we usually obtain for this is bone marrow or blood that is set up in an unstimulated culture with at least 20 metaphases analyzed, and to be considered relevant, aberrations must be clonal. So switching gears to molecular testing, which is more of my area, this is something that we can perform on a variety of tissue types. We're not just limited to blood and bone marrow. And there's no lag time waiting for cell cultures to grow. And molecular methods, as we all know, tend to have a higher resolution than conventional karyotype. And array CGH, Sanger sequencing, and next generation sequencing fall into this category. So let's talk a little bit about chromosome aberrations. These are essentially change in chromosome number, structural abnormalities that include translocations, deletions, insertions, and inversions, which can be balanced, meaning there's no change in DNA copy number, or unbalanced, which indicates that there is a copy number change. This picture is actually showing a karyotype from the bone marrow of a female patient with ALL, and you can see the difference in how the chromosomes look compared to the slide I showed you before. And the individual chromosome pairs are identified when we're karyotyping by the unique G banding patterns. And the highlighted chromosomes here, which you can't really see on the screen, but what I'm trying to show is the derivative chromosomes 9 and 22 from the balanced 9-22 translocation, which we can see. So the other type of translocation that I wanted to make sure we mentioned are the cryptic translocations. And these are most likely what drives alternative methods of genomic detection, because these translocations that are prognostically significant but can be very hard to detect by conventional cytogenetic methods due to the size or chromosome location. And the most common example that I could think of one of these is the 1221 translocation, also known as ETV6 RUNX1. That would be very hard to see on conventional cytogenetics. Skipping over to fish, now that we've talked about chromosomes, multicolor fish techniques have also elucidated a novel chromosome abnormalities in complex karyotypes. And so what I'm trying to show you here, the top picture illustrates multiple color fish of a very, very abnormal metaphase taken from a child with acute lymphoblastic leukemia. And the color changes along the chromosomes indicate the locations and origins of the chromosome translocations. The bottom two pictures are metaphase fish taken from the bone marrow of a patient with T-cell ALL, and the karyotype indicated a 5-7 translocation, giving rise to the TLKX CDK6 fusion. The bottom left picture here shows a normal chromosome 5 with the red-green fusion signal, which is right here. Hopefully I don't advance the slide. And the red centromeric signal remains on the derivative chromosome 5, and the green telomeric signal is on the derivative chromosome 7. The bottom right picture here is of chromosome painting with the whole chromosome paint specific for chromosomes 5 and 7, which you can see the normal, and then the derivative chromosomes here. This technology was very much responsible for the discovery of cryptic translocations that I mentioned in the prior slide, such as ETV6 RUNX1. So now that we've spoken about chromosomes in fish, the most recent technology after that was really microarray. And microarray is an amazing technology because it has the ability to detect small genetic aberrations that are beyond the resolution of routine cytogenetics and often can detect areas that harbor genes of importance. So there are more than 50 recurring deletions or amplifications that have been identified, and many involve just a single gene or a few genes in total. And several of these genes are involved in multiple types of genetic alteration. So I think what we've been seeing is the combination of microarray used in conjunction with conventional cytogenetics has indicated that there is an increased detection rate from what we had before. So there are several flavors of microarray, at least when we're talking about copy number detection and variation. So this slide I show you briefly of how we set up microarray in a laboratory, and I think that's outside the scope of this talk today. But this is essentially a molecular DNA-based test that utilizes a specific probe, either oligonucleotide or SNP, and SNP stands for single nucleotide polymorphism. SNPs are variations at a single site in DNA and are the most frequent type of variation in our genomes. And it makes it a very good genomic marker. And this technology also allows us to detect loss of heterozygosity compared to our oligonucleotide array platforms. And so some regions that we may see loss of heterozygosity on SNP could indicate an underlying homozygous set of mutations in that area. So it's a very helpful technology. This is an Array CGH profile of chromosome 8 from an ALL sample run on a very high-resolution oligonucleotide array. And the ideogram of chromosome 8 is here on the left. And the profile from the array is here right next to it. And you can also see the probes and the displacement of probes here. So initially we see a shift to the left here, indicating a deletion at chromosome 8q2 3.3, and a shift to the right, indicating a high-level amplification of 8q2 4.21 that happens to include the MYC gene. So the high density of this array provides accuracy of breakpoint determination to within 600 base pairs. So you can appreciate that this technology is detecting aberrations beyond the ability of conventional cytogenetics in fish. And since we were talking about microarrays, I wanted to be complete and include expression microarrays. This is a technology that is not looking for copy number variation, but it utilizes a sample of complementary DNA, or cDNA, that's generated from mRNA to evaluate the transcriptome. And this cDNA is labeled with fluorophores, hybridized to chips that are spotted with probes that have areas of interest in them. And the signals from those fluorophores are captured and analyzed, and the intensity of the signal, gene targeted by the spot on the probe, is evaluated. And then we are able to know how much cDNA is present, and therefore how much mRNA is present, and therefore what the expression of that gene is. So prior studies have demonstrated that expression profiling can be quite effective in classifying lymphoblastic leukemia and prognostically important subtypes that were previously discussed today. And this is one of my favorite slides because it really ties everything that I've been talking about together. And this slide is illustrating the use of a variety of methods in identifying intrachromosomal amplification of chromosome 21, which also is known as amplification of RUNX1. So here in picture A, there is a partial G-banded karyotype showing pairs of chromosomes 21 taken from 6 different patients with ALL. And the normal chromosome 21 is here on the left, and its abnormal counterpart is here on the right. And you can see how variable the chromosomes look in morphology here. In picture B, there is G-banding and M-banding partial karyotypes, with the normal chromosome 21 here on the left and the abnormal chromosome 21 here on the right. And these are from patients, again, with IMP 21. And M-banding here, you can see, really indicates that there's complex intrachromosomal rearrangements along that Q arm of chromosome 21. In picture C, this is a metaphase fish, and there's a single signal from RUNX1 on the normal chromosome 21, and then you see additional RUNX1 signals on the abnormal chromosome 21. In picture D, this is interface fish, and it's showing using probes to look for the ETV6 RUNX1 fusion. And this picture is showing multiple copies of the RUNX1 gene in red here, and then the 2 normal copies of the ETV6 gene here. And then in picture E, this is the microarray of 3 different patients with IAMP21. And you can really see here the variability amongst all the patient samples. And I think that really reflects what we're seeing here on the cytogenetics. But there is a common amplified region amongst all 3 patients in the area of 21q22, which contains RUNX1. And then 2 of the patients also have a deletion of the subtelomeric region on chromosome 21. Thus, I think it may be safe to say that at this time, fish with probes directed to RUNX1 gene remains a reliable detection method in the clinic for this abnormality. This is a genome browser that I probably use a couple times a day in my clinical practice of mostly prenatal and postnatal genetics. I also like to say it has a wonderful cancer genome browser, which is something that allows visualization of segmented copy number variation profiles depending on the condition or gene of interest. And you've also seen a version of this slide in Dr. Blyer's talk. And since the focus of this meeting is about breakdown of barriers between age groups of ALL, I really liked this chart because I feel that it really shows the differences by age from a genomic standpoint. This chart was generated from karyotype data collected from more than 4,000 childhood and adult ALL patients entered into UK treatment trials. And the incidence of the most specific aberrations tend to vary by age, as we all know. So infants tend to have a high frequency of rearrangements involving the MLL gene, which is seen in royal blue here. Adults have a higher proportion with the Philadelphia chromosome, seen in magenta here, as well as the association of the poor prognosis. And Dr. Mulligan was talking a little bit earlier today about some of his work with respect to this. Younger patients tend to have a predominance of good risk abnormalities, including high hyperdiploidy, seen here in orange, and translocation 1221, seen here in yellow. IAMP21 and IGH translocations are in older children and adolescents, and translocation 119 here in lilac really is a rearrangement that occurs in most age groups at approximately the same rate. Older children and young adults comprise the largest groups with unspecified chromosome abnormalities here, indicating the potential for discovery of novel cytogenetic changes. In general, age-related cytogenetic profiles that are specifically associated with children, adolescents, and adults have emerged and really define ALL as distinct entities according to age and genetic abnormality. And I wanted to touch a little bit on genome-wide testing. Array CGH, as I had mentioned, had illustrated that genetic lesions driving leukemogenesis often occur at the submicroscopic level. And so Mulligan et al. In 2007 showed that the detection of minute changes in copy number by SNP arrays led to the important discovery that disruption of genes involved in normal B-cell development and differentiation played an essential role in leukemogenesis. In childhood B-cell ALL, most likely genes involved in both B-cell developmental pathway as well as cell cycle progression processes are what we think really trigger the development of ALL. Although identifying new candidate genes, in my opinion, can sometimes be likened to looking for a needle in the haystack, but I think we're going to get there. So I think genome sequencing within the next few years, maybe I'm optimistic, but I think we'll identify all somatic genetic alterations that are present in ALL. And I think efforts will also be really focused on further characterizing somatic genetic aberrations in coding genes, but we should also be looking at inherited variations that could be also contributing to leukemogenesis. And this aids in determining the role as well of non-coding genomic variation in leukemia development. And so my last slide here is to really talk about where I think we're going to go. But I really want to start by saying that cytogenetics still fills a niche in the diagnosis of this condition. But rapid advances in our technology and next-generation sequencing is really going to make a whole genome approach much more widely available in the clinic. And there is an incredible great interest in the use of these high-resolution genomic profiling to help us characterize the genetic basis, to understand and predict treatment failure, as well as to find new novel markers and know how to use those novel markers for treatment. And I'm sure that you'll hear about some of these later on in this conference. So I also want to tell you that there are a lot of patients that we see that don't have identified cytogenetic changes. And ultimately, our end goal is to improve outcome for patients with this condition. Thank you very much.